नमस्ते बिटिया हमेशा खुश रहो बिटिया and namaste to all JVNs. I, JVN Dr. Ravi Jain, Associate Professor and HOD, Department of Practice of Medicine and Faculty of Homeopathic Science at JAYOTI VIDYAPEETH Women's University, Jaipur. On this day of Ganesh Chaturthi, that is on 19th September 2023, Tuesday, we are going to discuss about the thyroid disorders, especially thyrotoxicosis or hyperthyroidism. In the last lecture, we have discussed in detail about hypothyroidism. We have discussed what is hypothyroidism, what are the different causes of hypothyroidism, what are the clinical features of hypothyroidism, the investigation of hypothyroidism and its management. In this lecture, we are going to discuss about hyperthyroidism, what is hyperthyroidism, and thyrotoxicosis, what are the clinical features that we are going to see in a patient, and how to investigate a case of hyperthyroidism and what is the management. So let us start with hyperthyroidism. Hyperthyroidism is also known as thyrotoxicosis. Thyrotoxicosis is a state of thyroid hormone excess. That is, there is excess of thyroid hormone. There are various causes of thyrotoxicosis. As we have discussed in hypothyroidism, there were different causes. In the similar way, there are various causes in the thyrotoxicosis development. Thyrotoxicosis is caused by various diseases like Graves' disease or toxic multinodular goiter or toxic adenoma. So there can be Graves' disease, toxic multinodular goiter, or toxic adenoma. It can be classified into three different types. That is primary, as we have discussed in the hypothyroidism, there was primary, transient, and secondary. In the similar fashion, thyrotoxicosis or hypothyroidism is of again three types. Number one, we have primary hyperthyroidism. Second, we have thyrotoxicosis without hyperthyroidism. And third is secondary hyperthyroidism. So three types include number one, primary hyperthyroidism. Second is thyrotoxicosis without hyperthyroidism. And third is secondary hyperthyroidism. Now, what are the different causes of primary hyperthyroidism? Primary hyperthyroidism is basically disease that is related to thyroid itself. And secondary means when the disease is related to other factors, other disease factors leading to thyrotoxicosis. So primary hyperthyroidism, when the hyperthyroid is developed because of the defect in the thyroid gland itself. So the various causes of primary hyperthyroidism includes Graves' disease. We have toxic multinodular goiter, toxic adenoma, struma overi, and there are various drugs that includes iodine excess that is known as Jod-Basedow syndrome. The second variety includes thyrotoxicosis without hyperthyroidism, means there is increased level of thyroid hormone in the blood, but there is no hyperthyroidism. The causes of thyrotoxicosis without hyperthyroidism include subacute thyroiditis, silent thyroiditis, and other causes of thyroid destruction, which includes radiation, infarction, or adenoma. Ingestion of excessive thyroid hormone, that is known as thyrotoxicosis factitia, can also lead to development of hyperthyroidism. That is thyrotoxicosis without hyperthyroidism. Now, what are the various causes of secondary hyperthyroidism? Secondary hyperthyroidism means there are other organs that are responsible for development of hyperthyroidism. This includes TSH secreting pituitary adenoma, TSH secreting resistance syndrome, and occasional patients that may have features of thyrotoxicosis. Chorionic gonadotropin secreting tumor or gestational thyrotoxicosis means when there are other organs that are secreting thyroid hormone that will lead to development of thyrotoxicosis in an individual. So the secondary causes of hyperthyroidism includes TSH secreting pituitary adenoma. When the pituitary gland will be secreting more and more TSH, that will stimulate the thyroid gland to stimulate more and more T3 and T4. There can be thyroid hormone resistance syndrome. There can be chorionic gonadotropin secreting tumors and gestational thyrotoxicosis. Now, whenever a patient of thyrotoxicosis will be coming to you, what are the clinical features or the symptoms that you are going to observe in that particular patient? We have discussed the features of hypothyroidism in the last lecture. Today, we are going to discuss the features of hyperthyroidism or thyrotoxicosis. The symptoms of thyrotoxicosis are exactly opposite to that of the symptoms of hypothyroidism. The symptoms of thyrotoxicosis or hyperthyroidism includes hyperactivity, irritability, and dysphoria. Hyperactivity, irritability, and dysphoria. There is heat intolerance and sweating. There will be palpitations, means increased heart rate, with fatigue and weakness. In hypothyroidism, we have seen that there was weight loss, weight gain, despite of poor appetite. On the contrary, in case of hyperthyroidism, there will be weight loss with increased appetite. There will be diarrhea. In case of hypothyroidism, there was constipation. In case of hyper, we have diarrhea. There will be polyuria, oligomenorrhea, loss of libido. So the symptoms of hyperthyroidism are exactly opposite to that of hypothyroidism. The symptoms includes hyperactivity, irritability, dysphoria. There will be heat intolerance and swelling and sweating. There will be palpitations, fatigue and weakness. There will be weight loss with increased appetite. The patient will complain of diarrhea, polyuria, oligomenorrhea, and loss of libido. The signs of hyperthyroidism or thyrotoxicosis includes tachycardia, that is increased heart rate over 100 beats per minute. In hypothyroidism, there was bradycardia, that was pulse rate below 100, below 60. And in case of thyrotoxicosis, we have tachycardia, that is heart rate above 100. There are tremors, that is involuntary shaking of the hands. The patient has goiter. In hypothyroidism, the skin was cooled. But in case of hyperthyroidism, there is warm and moist skin. In hypothyroidism, it was cold and dry. There will be muscle weakness in case of hyperthyroidism, and proximal myopathy will be seen. There will be lid retraction or lid lag, that is, the lid is not able to close properly. The male patient is also going to complain of gynecomastia. So in the features of the signs of hyperthyroidism or thyrotoxicosis, we have tachycardia, that is atrial fibrillation in the elderly. There will be tremors, goiter, warm and moist skin will be seen. There will be muscle weakness with proximal myopathy. The patient will complain of lid retraction or lid lag, and there will be gynecomastia in males. Now let us discuss about the Graves' disease. Graves' disease is an important disease that is responsible for development of thyrotoxicosis. It accounts for around 60 to 80% of the cases of thyrotoxicosis. Means Graves' disease is responsible for 60 to 80% of thyrotoxicosis in the given population. The prevalence varies among the population, reflecting there are various genetic factors and iodine intake that leads to development of Graves' disease. It occurs in around 2% of the women, but 1/10 as frequent as in men. Graves' disease occurs in the age group between 20 to 50 years of age. Now, what are the various factors that predispose for development of Graves' disease? The predisposing factors includes various genetic and environmental factors. There will be stress factors, smoking, and sudden increase of the iodine intake and postpartum period. So the predisposing factor that leads to development of thyrotoxicosis includes environmental and genetic factors. We have stress factors, smoking, sudden increase in the iodine intake, and postpartum period. Now, what is the pathogenesis? That is, what are the changes that are taking place in the thyroid gland in case of thyrotoxicosis or Graves' disease? The hyperthyroidism of Graves' disease, it is caused by TSI, that is thyroid stimulating immunoglobulins, that are synthesized by the thyroid gland as well as by the bone marrow and lymph nodes. In the long term, there is spontaneous autoimmune hypothyroidism that may develop in up to 15% of the patients with Graves' disease. So in the pathogenesis, there is thyroid stimulating immunoglobulins synthesized in the thyroid gland, in the bone marrow and lymph nodes. And in the long term, autoimmune hypothyroidism develops in around 15% of the cases. Now, what are the causes of ophthalmopathy that is seen in the hyperthyroidism or thyrotoxicosis in Graves' disease? There are various changes in the eyes that are seen in Graves' disease, and these changes are known as ophthalmopathy. Now, what happens is the cytokinins play an important role in the development of ophthalmopathy. There is infiltration of the extra auricular muscles by activated T cells. So in the eyes, we have extra auricular muscles, extraocular muscles that are infiltrated by the T cells, and they release the cytokinins that result in fibroblast activation. So extraocular muscles are infiltrated by the activated T cells, and they release cytokinins, and this results in fibroblast activation and increased synthesis of glycosaminoglycans. That these glycosaminoglycans that we have also seen in hypothyroidism, they trap water and leading to the development of muscle swelling. Later in this disease, these are irreversible. There is irreversible fibrosis that is seen in the muscles, and there is increase in the intraorbital pressure that can lead to proptosis, diplopia, and ocular neuropathy. Now, what are the clinical manifestations of the Graves' disease? Whenever a person of Graves' disease is coming to us, what are the various features or clinical features that the patient is going to exhibit? There is clinical presentation depends on the severity of thyrotoxicosis. So, depending upon the severity, the clinical presentation of Graves' disease takes place. Severity of thyrotoxicosis, how much severe the thyrotoxicosis is, what is the duration of the disease, and what is the individual susceptibility to thyroid hormone and the patient age. There can also be apathetic thyrotoxicosis that occurs in the elderly patients and mainly associated with fatigue and weight loss. The thyroid, in case of Graves' disease, is usually diffusely enlarged. So the goiter or the thyroid gland is enlarged 2 to 3 times the normal size, and the consistency is firm but not nodular. So when you touch that thyroid gland, you are going to feel firm consistency of the thyroid gland, and when you are going to put your stethoscope and you are going to hear for the blood flow, then you are going to feel the thrill or a bruit that is best detected on the inferior lateral margin of the thyroid lobes. So on the inferior and lateral margin of the thyroid lobes, you are going to uh, listen the bruit or the thrill sound by the stethoscope due to the hyperdynamic circulation of the blood flow. Now, Graves' ophthalmopathy. Now, what are the features of clinical features that we are going to see in case of Graves' ophthalmopathy? That is changes in the eyes. There will be sensation of grittiness or mud-like sensation with the discomfort of the eyes and excessive tears formation. So, grittiness and like sensation, eyes discomfort, and lot of tears formation. There will be proptosis. Proptosis means protruding of the eyelids, eyes because of the corneal exposure and damage. The lids fails to close. The lids cannot be closed, and during the sleep, there will also be periorbital edema around the eyes. There will be edema. There will be redness of the eyes. The redness of the eyes will be known as scleral injection, and there will be chemosis also frequent. The muscle swelling also develops in diplopia, results in diplopia. The diplopia means double vision. The most serious complication of the this manifestation is the compression of the optic nerve, and this when this optic nerve is compressed, this can lead to permanent vision loss. Now there is we have developed a system that is known as NOSPECS, NOSPECS, that is a scoring system for evaluation of the ophthalmopathy in case of Graves' disease. In Graves' disease, ophthalmopathy plays a very important role. So NOSPECS, we have grades from 0 to 6. In grade 0, there are no signs of symptoms that stand for N. Grade 1, when only signs are present, only signs means lid retraction with no symptoms. Grade 2, when there are soft tissue involvement, that consists of periorbital edema. In grade 3, we have proptosis. Grade 4, there is extraocular muscle involvement that will be leading to development of diplopia. In grade 5, there is corneal involvement, and grade 6, we have sight loss due to the compression of the optic nerve. So grade 0, no sign and symptom. Grade 1, only signs and no symptoms. The signs include lid retraction or lid lag. Grade 2, there will be soft tissue involvement that will lead to development of periorbital edema. Grade 3, there will be proptosis. Grade 4, extraocular muscle involvement leading to diplopia. Grade 5, corneal involvement. Grade 6, we have slight sight loss. There, the patient also complains of thyroid dermopathy. Thyroid dermopathy includes pretibial mixed edema, with most frequent over the anterior or lateral aspect of the leg. The typical lesion is non-inflamed. The lesion is non-inflamed with indurated plaque with a deep pink or purple color and with an orange skin. The patient also complains of thyroid arthropathy, that is clubbing of the fingers, seen in less than 1% of the individuals. Now, lab evaluation. Whenever a person of Graves' disease is coming to us, how can we evaluate or what are the changes that we are going to see in the lab? Usually, when there is thyrotoxicosis, the levels of T3 and T4 are high, so ultimately the TSH level is low. Thyroid stimulating hormone level is low or suppressed, and total and unbound thyroid hormone levels are increased. So TSH low, T3, T4 high. We have to measure the TPO antibodies, that is thyroid peroxidase antibodies. The diagnosis of Graves' disease is straightforward in a patient with biochemically confirmed thyrotoxicosis. There will be diffuse goiter. The goiter will be enlarged 2 to 3 times in normal size, and it will be firm or not nodular. There will be ophthalmopathy. We have just seen most specs ophthalmopathy that will be seen, and often the person is having the family history of hyperthyroidism or autoimmune disorders. The diagnosis of Graves' disease is done generally established by radionuclide scanning using technetium 99, iodine 123, and iodine 131 scans that uptake the thyroid taken by the thyroid gland. Scintigraphy is preferred diagnostic test for the diagnosis of Graves' disease. Now, what are the differential diagnoses of Graves' disease? There are various diseases that resemble Graves' disease that includes secondary hyperthyroidism due to TSH secreting pituitary tumor. There will also be diffuse goiter in presence of non-suppressed TSH level. The clinical features of thyrotoxicosis can mimic certain aspects of other diseases like panic disorders. There will be mania, pheochromocytoma, and weight loss can be associated with malignancy. The diagnosis of thyrotoxicosis can be easily excluded by the TSH level and T3T4 levels when TSH is high and T3T4 are normal. A normal TSH also excludes the Graves' disease as a cause of diffuse goiter. Now, how to treat the case of Graves' disease? Whenever a patient of Graves' disease is coming to us, how can we treat the patient? The treatment consists of reducing the thyroid hormone synthesis using antithyroid drugs, or second is by reducing the amount of thyroid tissue with the radioiodine treatment by thyroidectomy. So this is all about thyrotoxicosis or hyperthyroidism. All right, we have discussed about thyrotoxicosis or hyperthyroidism. That is increase in the production of T3 and T4 and the reduced level of TSH. Yes, reduced level of TSH. And we have discussed about primary thyrotoxicosis without hyperthyroidism, and secondary thyrotoxicosis. We have discussed the clinical features of thyrotoxicosis that are exactly opposite to that of hypothyroidism. We also have seen the Graves' disease. We have discussed about the Graves ophthalmopathy. And we also have discussed about the investigation and management of hypothyroidism or thyrotoxicosis. Now, there is another important disease condition that is known as thyroiditis. So let us also cover this thyroiditis that we have just now discussed. There are various causes of thyroiditis. Thyroiditis is basically inflammation of the thyroid gland. There are various causes of thyroiditis that includes acute, subacute, and chronic thyroiditis. Acute, subacute, or chronic. Acute thyroiditis can be caused by bacterial infection, fungal, or radiation therapy. In the bacterial infection, especially Staphylococcus, Streptococcus, and Enterobacter, the fungal infection is caused by Aspergillus, Candida, and Coccigoides, Histoplasma, and Pneumocystis, and radiation thyroiditis after iodine 131 treatment. Subacute thyroiditis is caused by viral thyroiditis, or it can be silent thyroiditis or drug-induced. Chronic thyroiditis usually occurs with the autoimmunity. It is associated with focal thyroiditis, Hashimoto thyroiditis, atrophic renal thyroiditis, parasitic thyroiditis that occurs because of echinococcus and strongyloides, cysticercosis, or traumatic that is after palpation. More and more palpation of the thyroid gland leads to development of chronic thyroiditis. The most important of these thyroiditis is subacute thyroiditis, that is also known as D. Quervains thyroiditis. This is a question that is mostly coming in the short route in the exams. D. Quervains thyroiditis or the granulomatous thyroiditis or viral thyroiditis, it is caused by the viral infection. Viral infection, especially mumps, Coxsackie, influenza, adeno, or echovirus. The symptoms can mimic pharyngitis, and there is peak incidence of around 30 to 50 years of age. Women are 3 times more frequently affected than men. Now, what is the pathophysiology of subacute thyroiditis? In case of subacute thyroiditis, there are patchy inflammation infiltrate that are with the disruption of the thyroid follicles. In the initial phase, there is follicular destruction of the thyroid gland, and there is release of thyroglobulin and thyroid hormones in the blood circulation. So, in case of subacute thyroiditis or D. Quervains thyroiditis, first of all, there is disruption of the thyroid follicles by the inflammatory infiltrate that leads to destruction of thyroid follicles, and this causes release of the thyroglobulin into the blood circulation. When the thyroglobulin is released into the blood circulation, it causes increased level of T3 and T4 and reduced level of TSH. During the destructive phase, radioiodine uptake is low and undetectable. After several weeks of this phase, the thyroid stores are depleted, and the phase of hyperthyroidism turns into hypothyroidism. Because the thyroglobulin are exhausted, T3, T4 is completely exhausted, Now the patient goes into the state of hypothyroidism that is characterized by low level of T3, T4 and higher level of TSH. Now the radioiodine uptake returns to normal and is increased with as a result of rise in TSH. Finally, the thyroid hormone level comes to normal and the disease subsides in few months. So in case of subacute thyroiditis, we are seeing three stages. One is the stage of thyrotoxicosis, second is hypothyroidism, and third is the euthyroid state. Now, what are the clinical manifestations of subacute thyroiditis? The patient usually presents with painful and enlarged thyroid gland accompanied by fever. There are some features of thyrotoxicosis or hypothyroidism based on the stages. Initially, we are seeing hypothyrotoxicosis. Later on, we are seeing hypothyroidism, and then the patient is coming to euthyroid state. There can be also symptoms of sore throat. Examination reveals small goiter that is painful, that is tender to touch. The pain often radiates to ear, lower jaw or ear. Complete resolution is usually an outcome, but late onset or permanent hypothyroidism can occur in 15% of the cases. Now, how to diagnose a case of subacute thyroiditis? Thyroid function test usually evolves in three distinct phases. First of all, we have thyrotoxicosis phase when the thyroid gland was destroyed, the follicles were destroyed. At that phase, T3, T4 were high, TSH was low. Second is hypothyroid phase when the stores were depleted. At that time, T3, T4 is low and TSH is high. And recovery phase when the levels remains to normal. Now, what is the treatment of subacute thyroiditis? So, large doses of aspirin or NSAIDs to control the symptoms. Local systemic symptoms like glucocorticoids reduce the inflammation. And thyroid function has to be done every 2 to 4 weeks using TSH and unknown T4 levels. Levothyroxine replacement therapy is needed if required in some cases when hypothyroidism is prolonged. So this was all for today, and I hope you must have understood the thyrotoxicosis. And we have also discussed about uh, Quervains thyroiditis or the subacute thyroiditis. In the next lecture, we are going to discuss about goiter. We are going to discuss about goiter in detail. So this was all for today. I hope you must have understood the session properly. Even if a doubt arises, we can discuss about these doubts in the classroom itself and we can sort it out. So this was all for today. Thank you very much. Have a good day.